Hello, ladies and gentlemen, and thank you for waiting. Welcome to the LSQIN Understanding Quality Measures call. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Kathy Nichols. Kathy, the floor is yours.
Thank you, Erin. Hello, everyone. This is Kathy Nichols with Stratis Health, a Minnesota organization that is part of the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this educational session entitled Understanding the Nursing Home Quality Measures. We know that most nursing homes are working hard on making quality improvements to improve the quality of life and quality of care for those that live in your homes. We hope that what you learn today will help you to be successful in these efforts. This session is being recorded and will be available in about 2 weeks. All lines will be muted during this webinar. However, after the presentation, we will have a time for questions and answers, so please make a note of any questions that may come up as you listen. If we should happen to run out of time, we'll give you directions for getting questions to us. We also have included in the chat function how to access the handouts if you still need them. We are very pleased today to have Nadine Olness, the Minnesota RAI Coordinator and Case Mix Review Nurse Educator at the Minnesota Department of Health, as our guest speaker today. Nadine is a registered nurse with extensive background in long-term care. She is Certified Resident Assessment Coordinator and a current member of the AHFSA RAI Panel. Also with us is Kristi Wergin, a Program Manager at Stratis Health. She provides quality improvement leadership for Minnesota nursing homes as part of the CMS Quality Innovation Network Quality Improvement Organization contract and leads the team in Minnesota that is assisting nursing homes in their quality improvement efforts as part of the National Nursing Home Quality Care Collaborative. Welcome, Nadine, and thank you for being with us today. I will now turn the presentation over to you.
Thank you. Thank you. We're going to talk today about quality measures, and we're going to start with, first, what is a quality measure? The objectives are there for you. In October 2010, CMS released a new version of the MDS 3.0. Around that same time, CMS contracted with RTI International to develop quality measures for skilled nursing facilities. The quality measures were developed using the MDS 3.0 assessment data that all certified nursing facilities routinely collect on their residents. In April 2012, CMS released the first Casper quality measure reports using the MDS 3.0 data. So why do we have these? Why do we need quality measures? Quality measures assess the residents' abilities, their preferences for care, and their physical and clinical conditions. Quality measures are one of the tools used to evaluate and improve the quality of care provided in skilled nursing facilities. Quality measures provide staff and consumers with another source of information to evaluate how well a nursing home is caring for their residents. Quality measure data is used in multiple ways. It is used in the public reporting systems, Nursing Home Compare, and the 5-star rating system, in addition to the CMS Casper reports, which is an internal rating system, and the National Nursing Home Composite Score. We will talk more about each of these in detail in a few minutes. But before we do, we need to go over a few definitions. It will help us better to understand the quality measure reports. A target period is the span of time that defines the quality measure reporting period. The target date is the event date for the MDS record. For an entry tracking record, a target date is the date in A1600, or the entry date to the facility. For a discharge record or a death in facility tracking record, the target date of the assessment is in A2000. For all other assessment types, the target date is the assessment ARD. An episode is a period of time spanning one or more states. An episode begins with an admission and ends with either a discharge return not anticipated, a discharge return anticipated if the resident does not return within 30 days, a death in facility, or the end of a target period. All residents whose latest episode either ends during a target period or is ongoing at the end of a target period are included in the quality measure calculations. If a resident has multiple episodes within a target period, only the latest episode will be used. An episode can include multiple stays. A stay is defined as a period of time between the resident's entry into a facility and either a discharge or the end of a target period, whichever comes first. So a stay begins with an admission or a re-entry and ends with a discharge of any type, a death in the facility, or the end of a target period. 2 resident samples are selected when computing quality measures, a short stay sample and a long stay sample. At any given time, a resident is either a short stay sample or a long stay sample resident. Which sample a resident is in depends on their cumulative days in the facility. The cumulative days in the facility is calculated for each episode. It is the total number of days within an episode that the resident was in the facility. When an episode consists of more than one stay, separated by periods of time outside of the facility, for example, if the resident was hospitalized or went on an LOA or home visit, only those days the resident was in the facility count towards the cumulative days in the facility. The cumulative days in the facility includes the day of entry, but not the day of discharge, unless the day of entry and discharge occurred on the same day. In this situation, the cumulative days in facility for that stay would be 1. If the cumulative days in facility is less than or equal to 100 days, the resident is included in the short stay sample. If the cumulative days is greater than or equal to 101 days, the resident will be included in the long stay sample. There are a total of 11 short stay and 19 long stay quality measures. 8 of these in each category are related to the influenza and pneumococcal vaccines. Quality measure data is used in a variety of ways. One of the ways in which it's used is the Nursing Home Compare website. Nursing Home Compare is a national public database that contains detailed information about every Medicare and Medicaid certified nursing home in the country. Nursing Home Compare allows consumers to compare the quality of care in one nursing home to that of another. Nursing Home Compare includes information regarding the facility's health and fire safety inspections, any penalties that were levied against the nursing home staffing levels, the quality measures, and the 5-star rating system. The Nursing Home Compare website uses 18 quality measures, 5 short stay and 13 long stay. The Nursing Home Compare website is updated monthly on the 3rd Thursday of the month. Health inspection and staffing data are updated monthly. NDS data is only updated quarterly. For more information regarding Nursing Home Compare, visit their website. The link for the website is included on the slide. Now, CMS announced last week that they made some changes to the Nursing Home Compare website. There's going to be changes in the way that the quality measures are calculated, which will ultimately affect how many stars the facility has. They also added 2 quality measures, the antipsychotic medication use, both long stay and short stay. The 5-star rating system is a component of Nursing Home Compare. The rating system features 1 to 5 stars for 3 performance measures. They are health inspections, staffing levels, and quality measures. In addition to these, the 5-star rating system includes an overall nursing home star rating. The star rating for the quality measure domain is based on the facility's performance in 11 quality measures, 3 short stay and 8 long stay. CMS added antipsychotic medications quality measures for both the long and short stay to the 5-star rating. Ratings for the quality measure domain are calculated using the 3 most recent quarters for which data is available. So data is averaged over 3 quarters. The quality measure data in Nursing Home Compare is updated quarterly in mid-January, April, July, and October. For more detailed information regarding how the 5-star rating is determined, see the Design for Nursing Home Compare 5-star Quality Rating System Technical User's Guide. The link for this has been added to the resources slide at the end of this presentation. The quality measure reports are also used to develop the Casper quality measure reports. Or the quality measure data, is used to develop the Casper quality measure reports. The Casper reports are internal reports that are used by CMS, the nursing home staff, and surveyors to evaluate and monitor the quality of care provided in nursing homes. The Casper quality measure reports are available on the Casper Reports website. The reports that are available are the MDS 3.0 Facility Characteristic Report, the Facility Level Quality Measure Report, the Resident Level Quality Measure Report, and the Submission Statistics by Facilities Report. The Casper system uses 17 quality measures, 3 short stay and 14 long stay. The quality measures used by the Casper system can be viewed on both the facility and resident level quality measure reports. You have a sample of both of these reports in your handouts. The Casper reports are an essential component to every nursing home's quality improvement process. These reports can help you identify potential problem areas within your facility. The Casper reports are also used by surveyors during the traditional survey process and by the QIS software in the QIS survey process to identify potential problem areas for investigation during nursing home inspections. Survey protocols direct surveyors to select any quality measure that is equal to or greater than the 75th percentile when selecting areas for review during a survey. The Casper system quality measure statistics are updated weekly to incorporate newly submitted MDS data. Some of you may have noticed that when you compare the quality measure data on your Casper reports to the data publicly available on Nursing Home Compare, that the numbers don't quite match. Even though the Casper reports in the Nursing Home Compare website use an identical sample selection and measure calculation logic, don't be surprised if you see differences between the results reported by the two systems. The quality measures used by the two systems are different. Casper uses 17 quality measures and Nursing Home Compare includes 18. Updates to the two systems are also completed at different times. Casper reports are updated weekly, where Nursing Home Compare results are updated quarterly. The reporting periods for the two systems are also different. Nursing Home Compare, the reporting periods are fixed, but in the Casper system, reporting periods can be customized. The Nursing Home Compare results are averaged across several reporting periods, while the results in Casper represent data from a single reporting period. And finally, the risk adjustments may be calculated at different times. The Casper reports would reflect the most current data available. Next, we're going to talk about how to access your Casper reports. You access your Casper reports through the CMS system. It really depends, I guess it should say that it really depends on how you submit your MDSs. If you submit your MDSs through the KEYS system, you can access your Casper reports through the Welcome to the CMS Systems for Providers page by clicking on the Casper reporting link. That's in red on your slide. This link will connect you to the KEYS National System login page. On the KEYS National System login page, you will need to enter your login information. If you do not have a user ID or password, you will need to go to the KEYS Technical Support Office and select and to request an ID. You will do this by selecting the MDS option in the Access Request Information box and then following the instructions for steps 1 and 2 under Individual Access. Once you have entered your login information, you will be redirected to the Casper Topics homepage. The Casper homepage is where you can access your Casper reports. The Welcome to Casper box on the screen contains a description of the various functions you can complete within the system, including requesting and reviewing your reports. To complete these functions, you can either use the toolbar at the top of the page or select the underscored links in the Welcome to Casper box. To access your Casper Quality Measure reports, click on the Reports link. This will bring you to the Casper Reports page. Something to remember that when you're navigating within the Casper system, you do not want to use your browser's back, forward, or refresh buttons to make changes to the data or to go between pages. Instead, you want to use the back and refresh buttons provided within the Casper reporting application. If you use the browser's buttons, you may not get the results that you expect. On the Casper Reports page, the Reports category pane on the left side of the screen lists the various report categories that are available. Some of the reports are restricted to specific users or user groups. The reports categories available may be different from the ones that are available to you may be different than the ones that are shown on this screen. The pane on the right of the screen lists the reports available in the selected report category. This list may span multiple pages. If so, use the page number links at the bottom of the pane to navigate from one page to another. In the left pane, under the report categories, select the MDS 3.0 Quality Measure Reports. A list of available quality measure reports will then appear on the right side. In the right pane, you always want to make sure that you choose the MDS 3.0 Quality Measure Package Reports. This option includes the four reports: the Facility Characteristic Report, the Facility Quality Measure Report, the Facility Level Quality Measure Report, and the Resident Level Quality Measure Report. A fourth report is also available. It is the Submission Statistics by Facility Report. This report identifies all of your submissions, when they were submitted, and the percent of rejected records. This report is also used by surveyors when they're doing their nursing home pre-inspection prep work. This is an optional report. It is not checked. If you want that report, you would just simply select or check the box next to the Submission Statistics by Facility Report box. On the next screen, you will need to specify the desired report criteria, including the facility name or identification number and the reporting period. The Casper system will automatically select a 6-month reporting period. However, these dates are customizable, so if you want to customize your dates, you want to make sure that you choose a 6-month report period. If you do not, your quality measure data may not calculate correctly. The comparison group data is delayed by 2 months. The default reporting period identified in the comparison group field is the most recent information available. However, you can select earlier periods from the drop-down list if you choose. Once you've identified your facility name, identification number, and the reporting period, you would just click on Submit. The length of time needed to generate Casper reports varies depending on the length and number of reports requested at any given time. It may take a few minutes to receive your reports. You want to be patient. Or you can always log out of the system and then log back in at a later time. If you choose to log out and come back at a later time, you will find your reports in your My Inbox. You can also check on the progress of your reports if it's taking a little longer to get your reports than you anticipate by clicking the Queue button in the Casper toolbar. The Queue button identifies how many reports are currently processed for all users nationwide and where your reports are in the queue. The refresh screen, if you refresh your screen, the status of your selected reports will then be refreshed and you'll know where they are in the queue. When your report is no longer listed in the queue, it is done processing. The completed report has been sent to your inbox, to your My Inbox. To select your My Inbox, you want to click on the Folders tab. The Folders tab will bring you to your My Inbox folder, where you'll find your reports. For more detailed information regarding how to access, print, or save your Casper Quality Measure reports, see Section 2 of the Casper Reporting MDS Provider User's Guide. A link to this guide is provided in the resources slide at the end of this presentation. Now that we have our quality measure reports, we're going to discuss how to interpret them. So everybody should have the three handouts of the various quality measure reports. First, we're going to take a look at the MDS 3.0 Facility Characteristics Report. This report provides facility demographic information, and it includes comparison state and national percentages for the specified time frames. The demographic information includes a breakdown of the residents in your facility by age, gender, diagnostic characteristics, prognosis, discharge plans, referrals, type of entry, and where the resident entered from. The Facility Characteristics Report identifies potential areas for further emphasis or review as part of the facility's quality improvement process. By comparing the facility percentages with the state and national average percentages, you can determine whether your facility's demographic characteristics differ from the norm. A facility's characteristics may indicate a need to concentrate a review on a certain resident population. For example, if you have a high percentage of hospice care patients, you might want to concentrate your review in that population. Or say you have a high percentage of psychiatric diagnoses. The Facility Characteristics Report is also reviewed by surveyors in a traditional survey process prior to entering the facility. Let's take a closer look at this Facility Characteristics Report. We can see that our facility has a significantly lower observed percentage than the state national average in discharge plan not already occurring, and a significantly higher observed percentage than the state and national percentage in discharge planning already occurring, hospital admissions, and referrals. From this report, one might conclude that the facility receives a lot of short-term rehab admissions. These are some of the things we should keep in mind when we continue looking at our other reports. Next, we will look at the MDS 3.0 Facility Level Quality Measure Report. For each quality measure, the Facility Level Quality Measure Report identifies the facility percentage of how the facility compared to other facilities in the state and in the nation. This report helps facilities identify possible areas for further emphasis in their quality improvement activities. This report is also used by surveyors and the QIS software to identify potential areas for investigation during the survey process. The top left portion of this report identifies the facility information. For our purposes today, this has been removed from the report. This is also where you will find the date the data was calculated on. On the top right portion of the report identifies the reporting and the comparison group reporting period. Note that both are 6-month periods, as well as you will also find the date that the report was actually run on. The 17 quality measures used by the Casper reporting system are listed in the left-hand side of the table. The quality measures is followed by either an S, indicating a short-stay quality measure, or an L, indicating it is a long-stay quality measure. The next column over identifies the CMS ID. The CMS ID is a unique identification number assigned to each quality measure by CMS. In the next column, you will see the word NUM. NUM is short for numerator. The numerator is the number of residents in the facility who have the condition and actually triggered the quality measure. Continuing on, we see the word denom. Denom is short for denominator. The denominator is the number of residents in the facility that could have the condition, but did not trigger the quality measure. For some quality measures, the number of cases in the denominator will equal the current number of short-stay or long-stay residents in the facility. But for other measures, the denominator is smaller because of exclusions that were applied to the denominator. We will talk more about exclusions in just a few minutes. The facility observed percent is determined by dividing the number of residents who triggered the quality measure, the numerator, by all the residents who could have the quality measure and did not trigger it, or the denominator, and then multiplying that result by 100. The facility observed percent is the numerator divided by the denominator times 100. The facility adjusted percent is computed using a mathematical equation that takes various resident characteristics and the national percent for the measure into account and adjusts the observed percent accordingly. Measures that are adjusted have a different value in the observed and the adjusted percent columns. Note that on our sample report, the facility adjusted percent was modified for 2 of the quality measures: self-reported moderate to severe pain long stay, and new or worsening pressure ulcers short stay. If you want to know more about how the facility adjusted percent is calculated, you will look in Appendix A of the NVS 3.0 Quality Measure User's Manual. A link to this manual has been included on the resources slide at the end of the presentation. The comparison group state and national average column identifies the state and national average percentages for the quality measure. And the last column, the comparison group national percentile, ranks facilities relative to other facilities in the nation on each measure. The lower a facility's comparison group national percentile, the better. In our sample reports, the quality measure physical restraint long stay had a comparison group national percentile of 0. This indicates that the facility did not utilize restraints. Just above this is the new or worsened pressure ulcers short stay. The facility's national percentile rank is 68% for this quality measure. The higher the national percentile, the more likely the measure should be reviewed as part of the facility's quality improvement process or emphasized during a survey. Any quality measures with a comparison group national percentile that is equal to or greater than the 75th percentile is a potential area of concern during a survey. This report has 2 quality measures that flag above the 75th percentile. Those with major injury flagged at 85%, and low-risk residents who lose control of their bowel and bladder flagged at 83%. The third quality measure report is the resident level quality measure report. This report identifies the residents, both active and discharged, that were included in the calculations for the facility. This report lists the residents by name and identifies each quality measure the resident triggered, if any. The residents are listed in alphabetical order in two distinct groups, active residents and discharged residents. The resident ID is an internal ID that the QIS system, or system assigns to the resident. It is not an ID assigned to the resident by the nursing facility, and it is not the same as the resident ID field on the MDS. This is a special number that was been assigned by the KEYS system. The next column over, A0, 310A, B, and F, identifies the reason for assessment for the target assessment. The values in this column reflect how the reason for assessment items in A310A, A310B, and A310F were coded on the target assessment. These values can be found right on the MDS item set. For example, a value of 029999 would be interpreted as follows. An O2 coded in item A0310A indicates the target record was a quarterly assessment. A 99 coded in item A0310B indicates the target record was not a scheduled CPS assessment. And an A99 coded in an item A0310F indicates the target record was not an entry or discharge reporting record. So A029999 would indicate that the target record was a standalone quarterly assessment. So the target assessment for this resident was a standalone quarterly assessment. The next section of the report includes a column for each of the 17 quality measures used in the Casper system. A next appears in the quality measure column when the resident triggered the quality measure. These residents were included in the numerator. A B for blank appears for residents who did not trigger or for those who were excluded from the quality measure. The last column on the report identifies the total number of quality measures triggered for each resident. The resident level quality measure report can be used in two ways. First, it can be used to identify which residents triggered a particular quality measure by scanning down the column of interest and looking for the residents with an X. For example, let's look at Falls Long Stay. If we look at the Falls Long Stay quality measure, we see that 6 of the 14 residents identified on this page triggered the quality measure for Falls during the target period. Falls Long Stay. The second way that the resident level quality measure report can be used is to identify residents who trigger multiple quality measures. By looking at the last column on the report, we can see how many quality measures each resident triggered. So by looking at the quality measure count column for Jane Jackson, we see that the resident triggered 5 of the 17 quality measures. Residents who trigger multiple quality measures may warrant special consideration and a more intensive review. Now let's take a look at our facility level, a closer look at our facility level quality measure report. In our sample report, 2 quality measures flagged above the 75th percentile. Those with major injury long stay flagged at 85%, and low-risk residents who lose control of their bowel or bladder long stay flagged at 83%. The facility also came very close to exceeding the threshold for the quality measure behavior symptoms affecting others, long stay. They came in at the 74th percentile. Let's look at the falls with major injury quality measure data. The report indicates the facility had 5 of 82 residents experience a fall that resulted in a major injury. The facilities observed an adjusted percent was 6.1%, which is 2% above the state average and nearly 3% above the national average. This places the resident in the 85th percentile nationally, which means that 85% of the facilities, of the certified nursing facilities in the country, have equal to or less falls with major injury than this facility does. It is important to note that just because a quality measure exceeds the 75th percentile threshold, it does not mean there is automatically a problem. Exceeding the threshold merely indicates there is a potential problem, and the area of concern should be reviewed to determine if the problem truly exists, and if so, how is it being addressed. It must be said that the opposite is also true. Just because a quality measure did not flag does not mean there is not a problem with the quality of care in that area. Quality measure data is only one tool for both surveyors and staff to use. It is not the only information on which to base quality improvement activities or to make assumptions about the care provided in the facility. Surveyors and staff must consider all of the information available and use their best clinical judgment when making these decisions. I would like to draw your attention to the new and worsened pressure ulcer short stay quality measure. Although this quality measure did not exceed the 75th percentile threshold, it is on the high side, with 69% of the nursing facilities having equal to or less short stay residents with new or worsened pressure ulcers. When we reviewed the facility characteristics report, it appears that the facility had a lot of short stay additions, so this may be an opportunity for a quality improvement project. Now let's take another look at the resident level quality measure report. This report is usually multiple pages long, but for our purposes today, only one page of the report was provided. We're going to look at the quality measure falls with major injury, since this measure flagged at our facility level quality measure report at the 85th percentile. We need to determine which residents triggered the falls with major injury quality measure and when it was triggered. We also need to determine if any other quality measures were triggered by these residents to see if there's any correlation existing between the triggered care areas. The report indicates that 3 residents triggered the falls with major injury quality measure. Jane Jackson on her significant change in status assessment, John Johnson on his quarterly assessment, and Peter Peterson on his quarterly assessment. We can also see that all 3 of these residents triggered the low-risk residents who lose control of their bowel or bladder, and 2 of these residents triggered the antipsychotic medication use. There may be some correlation here. Are the residents falling while trying to get to the bathroom independently? Or maybe they're experiencing side effects related to their antipsychotic medication use. We should also note that Jane triggered 5 of the 17 quality measures, and John triggered 4 of the 17. Now that we know which residents and assessments triggered the quality measure, we are ready to start our investigation. To do this, we will need 2 things. We need a current MDS 3.0 quality measure user's manual and a current version of the RAI manual. A link for both of these manuals was provided on the resources slide at the end of this presentation. First, we're going to have to look at the quality measure user's manual. This manual identifies the quality measure's logic specifications. The measure description on the left side of the table indicates this measure reports the percent of long-stay residents who have experienced one or more falls with major injury in the target or look-back period. The measure specifications in the center of the table identify which residents are included in the numerator and who is included in the denominator. The numerator includes all long-stay residents with one or more look-back scan assessments that indicated one or more falls that resulted in a major injury, and this would mean that J1900C was coded a 1 or 2 on the target assessment. The denominator includes all long-stay residents with one or more look-back scan assessments except those with exclusion. So who was excluded from the denominator? You can see in the logic specifications that exclusions are present. Exclusions are variables that remove the resident from the denominator. Residents are excluded from the quality measure sample whose outcomes are not under the facility's control. For example, the outcome was present upon admission to the facility, or the outcome is unavoidable, say because the resident has end-stage disease or is comatose. All of the quality measures, all of the quality measures have exceptions, except for vaccinations. For this quality measure, a resident is excluded from the denominator and the numerator if the following is true for all of the look-back scan assessments. J1800 was dashed, indicating that the item was not assessed. J1800 is, it asks, has the resident had any falls since admission, re-entry, or the prior OBRA, scheduled PPS assessment, whichever is more recent. So the first exclusion is if J1800 was dashed, the resident is excluded from the denominator. The second exclusion for this item is the assessment indicates that the resident did have a fall, so J1800 was coded a 1, but the number of falls with major injury was not assessed. J1900 was dashed. We need to know what a look-back scan assessment is in order to investigate this problem, or a potential problem, I should say. The purpose of the look-back scan is to determine whether certain events or conditions occurred during the look-back period. A look-back scan is essentially a look-back period. There are two look-back scan periods, one for short stays and another for long stays. A short stay look-back scan looks at all the OBRA, scheduled PPS, or discharge assessments with target dates within the episode to determine whether the event occurred at any time during this period. Remember that an episode may include one or more stays, and an episode begins with an admission and ends with either a discharge return not anticipated, a discharge return anticipated and the resident does not return within 30 days, a death in facility, or the end of a target period. You also want to recall that a short stay measure includes only those residents whose cumulative days in the facility are equal to or less than 100 days. It's important to note that a short stay episode can span more than 100 calendar days because days outside of the facility are not counted in the cumulative days in the facility. The long-stay look-back scan looks at all OBRA, scheduled PPS, or discharge assessments within the current episode that have target dates no more than 275 days prior to the target assessment to determine if the event or condition occurred at any time during that 1-year period. The 275-day look-back scan is used to include up to 3 quarterly assessments, the earliest of which would have a look-back period of up to 93 days. So let's look at one of our residents. Let's look at John Johnson. John triggered falls with major injury. John was admitted to the facility and had remained in the facility for 5 years without a discharge. His quarterly assessment's target date was 12/31/14. The Lookback Scan then will look at all OBRA, scheduled TPS assessments, and discharge assessments within the target dates between 3/31/14 and 12/31/14 to see if a fall with major injury occurred at any point during that time period. So the Lookback Scan long stay measure for falls with major injuries, it looks back a year's worth of assessments. Now that we know how the quality measure triggered and who triggered it, we can begin our investigation to determine if the problem truly exists, or, if so, what is the root cause of the problem. Since the quality measure is triggered by MDS data, the MDS is a good place to begin your investigation. You will need to determine if the triggering assessments were coded accurately. To do so, you will need to know the coding requirements for the MDS items that triggered the quality measure, in this case, J1900C. The MDS defines a fall as an unintentional change in position coming to rest on the ground, floor, or next lower surface. A fall may be witnessed, it may be reported by the resident or another observer, or it may be identified when the resident is found on the floor. Falls include all falls, no matter where they occurred. A fall that occurs at home or while out in the community are all included in this item. Falls are not the result of an overwhelming external force. If the resident is pushed by another resident, and this results in a fall, this would not be considered a fall for MDS coding purposes. An intercepted fall occurs when a resident would have fallen had the resident not caught themselves or another person intervened. We also need to know what an injury is, or a major injury, and an injury related to a fall. An injury related to a fall is defined as any documented injury that occurred as a result of or was recognized within a short period of time, within hours or days, after a fall and was attributed to the fall. A major injury is defined as a bone fracture, a joint dislocation, a closed head injury with altered consciousness, or subdural hematoma. That's it. Nothing else. All other injuries are coded in injury except major, or 1900B. The steps for assessment for J1900 A through C direct us to determine the number of falls that occurred since admission, re-entry, or the prior OBRA or scheduled TPS assessment, and code the level of fall-related injury for each. We're directed to code each fall only one time. If the resident has multiple injuries from a single fall, code the fall for the highest level of injury. The coding instructions also tell us that if this is the first OBRA, PPS, or discharge assessment since the most recent admission or re-entry, we want to review the medical record for the time period from the resident's admission date to the ARD. Falls that occurred prior to admission are not included in this item. If it is not the first assessment, the review period is from the day after the ARD of the last MDS assessment to the ARD of the current assessment. After reviewing the coding instructions for the MDSs that triggered the quality measure, you may find that the root cause of the problem really wasn't falls at all, but instead it was an MDS coding problem. Maybe the MDS nurse didn't understand the coding definition of a major injury or was including falls that occurred prior to admission to the facility. Or maybe it was just a data entry error. It is possible that the problem really is falls, and its investigations revealed that the majority of the falls are occurring due to residents taking themselves to the bathroom or during change of shift times or on the night shift when there is fewer staff on the unit to assist residents with their toileting needs. The bottom line is that you want to get to the root cause of the problem. You need to determine why are the falls occurring. When are the falls occurring? Once you've identified the root cause of the problem, you've identified your quality improvement opportunity. You can develop and implement your plan, set measurable goals, monitor your results, and evaluate your progress towards your goal. If the results are not quite what you expected, you want to repeat the process. If your plan is successful, great. You have improved the quality of care in your facility and the quality of life for those residents that you serve. This last slide was put in here to show you that there is this, the quality measure logic specifications, there is a section for covariates on the table. It's the third column over. Very few quality measures have covariates. Covariates are resident-level risk adjustments. Quality measures are risk-adjusted in two ways: exclusions, which we already have discussed, and then covariates. Exclusions are facility-level risk adjustments, and covariates are resident-level risk adjustments. Covariates are variables that increase the risk of an outcome, either because it has a direct causal relationship to the outcome or because it influences the outcome in one way or the other. In this example up above here, this is for percent of residents who self-report severe to moderate pain, long stay. For this measure, a covariate or risk adjustment will apply if the resident was coded as independent or modified independence in daily decision-making, or on the prior assessment, if the resident has a BIM score of greater than or equal to 13. So there are only 3 quality measures that have covariates. They're new and worsening pressure, also short stay, self-reported moderate to severe pain, long stay, and a catheter inserted and left in the bladder, long stay. So if you want to know more about covariates and how they are calculated, you would also find that information in the quality measure user's manual. Okay, I think I'm going to turn that over. The last 2 slides in the presentation are slides that identify the resources links that are available. Thank you.
Thank you, Nadine, for sharing this great information about the quality measures. This is Kristi Wergin. I'm going to spend just a few minutes talking about the composite score. Let me just turn the... Oops, wrong way. Okay. So the composite score is a measure that will help you determine how well your nursing home has developed systems that support these quality measures. The composite score is calculated using the 13 long-stay quality measures that are publicly reported on Nursing Home Compare and reflect the cumulative effect of systems improvement. There are 13 measures that determine the composite score, and those are listed on this slide. The composite score is calculated by summing the 13 measure numerators to obtain the composite numerator, summing the 13 measure denominators to obtain the composite denominator, and then dividing the composite numerator by the composite denominator and multiplying by 100. So this methodology is based on what is called the opportunity model, because the denominator represents the number of opportunities to provide or reflect high quality care, and the numerator represents the number of times an opportunity was missed. So since the numerator represents the number of times an opportunity was missed, the lower the composite score, the better. Because the higher numerator, or that would be the higher number of opportunities missed, would create a higher composite score. So the bottom line is the lower the composite score, the better. This measure was created by the Centers for Medicare and Medicaid to measure the progress of the National Nursing Home Quality Care Collaborative. It is not intended to replace any existing CMS measure, such as the 5-star rating system, and it is not currently a publicly reported measure. The purpose of the composite score is to remove the desire to focus on one measure at a time, but rather focus on the systems that support these measures. Examples of systems that support these measures include such things as recruiting and retaining quality staff, teamwork and communication, good leadership, consistent assignment, and being a continuous learning organization. The composite score is not a public measure. Currently, composite score data are shared with all the Quality Innovation Network quality improvement organizations, such as the Lake Superior Quality Innovation Network. And the Lake Superior Quality Innovation Network will be sharing these data with all nursing homes participating in the National Nursing Home Quality Care Collaborative. So if you participate, you will receive reports that look similar to this, and participating homes will receive these reports at a minimum of each quarter. When reviewing your composite scores, keep in mind that the goal for the National Nursing Home Quality Care Collaborative is to achieve a score of 6 or better, and better, again, means lower. This was established as a goal because prior to the launch of the National Nursing Home Quality Care Collaborative, 10% of the nation's nursing homes were already performing at this level or better. So as you change the way you do your quality improvement work, by incorporating QAPI principles into your culture, you should see improvements in all of your quality measures. These improvements will then be reflected as a decrease in your composite score. However, keep in mind that there are likely multiple reasons why individual homes may have a high or low composite score, which may not necessarily reflect the quality of your home. I want to remind everyone of the opportunity for all nursing homes to join the National Nursing Home Quality Care Collaborative. Participants in this free collaborative will continue to have access to webinars like this, as well as other educational and collaborative opportunities. For questions about the composite score and further information about how to join the National Nursing Home Quality Care Collaborative, please contact your state lead in the Lake Superior Quality Innovation Network. And the contact information for the state leads are on this slide. And that brings us to the end of this webinar. So since we do not have time for questions or comments for Nadine or me, please refer, you can refer questions about the composite score to what we saw on this slide here, each lead from each state. Or questions about the quality measures, you can refer to your state RA coordinator. All right, well, this concludes the educational session. Thank you again, Nadine, for speaking with us today. You will all receive a link to a short evaluation form via email, and please take a minute to provide feedback on today's session. Once you've completed that evaluation, you will receive a certificate of completion. Please make sure that everyone on your team that has participated in this webinar receives a copy of the certificate. This session was recorded and will be available in about 2 weeks. Thank you all for participating, and have a great afternoon. This concludes the webinar.